Welcome to another episode from the Veterinary Medicine Digest. Today we embark on a deep dive into a topic that plagues countless small animal patients, urolithiasis, or the formation of stones within the urinary tract. This condition, which involves calculi obstructing or irritating the delicate urinary system, demands careful diagnosis and often complex medical or surgical intervention. To understand how best to treat and prevent these persistent problems, we must first appreciate the intricacies of stone formation, the challenges inherent in treating the lower and upper urinary tracts, and the rapidly evolving landscape of minimally invasive therapies available in veterinary medicine today. Segment 1. The complexities of stone formation. Urolith formation is not a disease in itself, but rather a complication stemming from various underlying disorders. These disorders, whether identified and correctable, like infection-induced stones, or poorly understood, like some calcium oxalate stones, often share a common mechanism. They create periods of oversaturation of urine with one or more crystal precursors. When the urine becomes oversaturated, crystal formation begins, initiating a complex physical process involving several major factors. These fundamental elements include supersaturation leading directly to crystal formation, the effects of certain substances that inhibit crystallization or crystal aggregation, the action of crystalloid complexers, the influence of promoters that encourage crystal growth, and finally, the presence of a non-crystalline matrix. For effective management, we must identify and either eliminate or modify these underlying abnormalities. While lower urinary tract stones occur commonly in both dogs and cats, the great majority, over 80% to 90%, are composed of just two main minerals, struvite and calcium oxalate. Stones are structurally composed primarily of one or more minerals combined with small amounts of organic matrix. It is important to note that stones are often not uniformly composed of a single mineral. They can be mixed, having uneven mineral mixtures throughout, or compound, exhibiting distinct mineral layers. The structure includes a nidus, where stone growth begins, the stone body itself, comprising the major portion, a shell surrounding the body, and surface crystals, which may form an incomplete outer coating. Determining the exact composition of the urolith is critical for developing a successful prevention and treatment plan, making laboratory analysis of any removed or voided stone essential, because guessing the composition based merely on appearance is highly unreliable. If stones recur, they should be analyzed again, as the mineral composition might change over time. Segment 2. The major mineral types, struvite and calcium oxalate. Let's begin with struvite stones, chemically known as magnesium ammonium phosphate hexahydrate. For these uroliths to form, the urine must be oversaturated with magnesium, ammonium, and phosphate ions. Struvite formation falls into two major categories: infection-induced struvite, which is common in dogs, and sterile struvite, which predominates in cats. Infection-induced struvite primarily affects dogs and typically occurs when a urease-producing microorganism, such as Staphylococcus species, Enterococcus species, or Proteus species, is present in the urinary tract. The enzyme urease drives struvite formation by altering the urinary environment, making the dog's diet less relevant in this specific scenario. This form of urolithiasis is more common in female dogs, given their increased susceptibility to urinary tract infections. The medical treatment for infection-induced struvite involves a two-pronged approach: feeding a specialized dissolution diet and administering an appropriate antimicrobial agent based on culture and sensitivity testing. Bacteria often become trapped within the stone's matrix and are released as the stone dissolves. Therefore, maintaining therapeutic levels of the antimicrobial agent throughout the entire dissolution process is crucial to prevent recurrence of the infection and cessation of dissolution. Dissolution typically takes around 79 days in cats and may take approximately 2 months, ranging from 1 to 4 months in dogs. Prevention relies solely on preventing and treating future bacterial urinary tract infections, as dietary modification alone does not prevent the recurrence of this type of struvite. In contrast, sterile struvite is the typical form seen in cats, usually between the ages of 1 and 10 years. This type of stone is linked to dietary factors and innate risk, as the absence of a bacterial infection means the urine environment itself promotes stone formation. Alkaluria, or alkaline urine, increases the risk for struvite formation, and studies show cats with naturally occurring sterile struvite often have a mean urine pH around 6.9. Sterile struvite dissolution is achieved through a diet that restricts magnesium, phosphorus, and protein, while also inducing aciduria, low pH, relative to typical maintenance foods. Increased water intake and promotion of dilute urine also help, as high urine volume reduces the concentration of calculogenic substances. Sterile Struvite uroliths in cats often dissolve rapidly, sometimes within just 2 to 4 weeks. Now we turn to calcium oxalate, which accounts for approximately 40% to 50% of all uroliths analyzed. Unlike Struvite, medical dissolution protocols are generally not successful for calcium oxalate stones, necessitating physical removal, whether surgical or minimally invasive. Calcium oxalate urolith formation occurs when urine is oversaturated with calcium and oxalate. Risk factors include increased urinary calcium or oxalate excretion and aciduria. Small dog breeds, such as miniature schnauzers, Lhasa Apsos, Shih Tzus, and Yorkshire Terriers, are predisposed, as are certain long-haired cat breeds. Preventive measures are critical, as calcium oxalate stones are highly recurrent. Dogs have an approximate 10% recurrence rate at 6 months and 35% at 12 months, and many cats see recurrence within 2 years if prevention is neglected. Since the exact underlying cause is often unknown, preventive strategies aim to maximize urinary inhibitors like citrate and magnesium, reduce calcium and oxalate concentration, decrease urine acidity, and, most importantly, promote dilute urine. Feeding canned food is the most practical way to increase water intake and reduce the urine concentration to a specific gravity of 1.040 or less in cats and 1.030 or less in dogs. Acidifying diets should be avoided or discontinued in cats prone to calcium oxalate, aiming for a neutral to slightly alkaline urine pH of 6.6 to 7.5 in both dogs and cats. If diet alone is insufficient to achieve the desired pH, potassium citrate may be administered. It is important to avoid vitamin C supplementation, as it is a metabolic precursor to oxalate, and high levels may increase urinary oxalate excretion. Furthermore, cranberry concentrate tablets, which contain high levels of oxalate and vitamin C and provide mild acidification, are contraindicated. Segment 3. The metabolic link, hyperlipidemia and obesity. Recent veterinary research has explored the association between calcium oxalate urolithiasis and metabolic factors often linked to obesity in humans. In dogs, a study investigating this link found that hypertriglyceridemia, or high serum triglyceride concentrations, was significantly higher in dogs with calcium oxalate lower urinary tract stones compared to stone-free control dogs, even when excluding breeds specifically predisposed to primary hyperlipidemia, such as the miniature schnauzer. The odds of having uroliths increased by a factor of 4.34 per mol/L of triglycerides when all breeds were analyzed in multivariable models. This strong association suggests that screening dogs diagnosed with calcium oxalate uroliths for high serum lipids should be considered to enhance their medical staging and management. In human medicine, dyslipidemia, particularly high triglycerides, is strongly associated with kidney stone risk, recurrence, and metabolic syndrome. The link between obesity, metabolic dysfunction, and stone formation in humans involves alterations in urine mineral content, leading to increased risk of both calcium oxalate and uric acid stones. In dogs, a diagnosis of obesity-related metabolic dysfunction is based on having a body condition score of 7 to 9 out of 9, along with 2 of the following conditions: elevated serum triglycerides, elevated serum cholesterol, elevated systolic blood pressure, or elevated plasma glucose. In the canine study on calcium oxalate, obesity, defined as a body condition score of 7 or greater, was significantly more frequent in dogs with uroliths than in the control group. However, when adjusting for age and sex in multivariable models, the effective body condition score was not retained, suggesting that factors like age or sex might better explain the difference in obesity rates between the groups. Despite this complexity, high glycemia was also significantly higher in dogs with calcium oxalate uroliths in univariate analysis. The underlying pathogenesis linking high triglycerides and stone formation remains unclear, but may involve changes in urinary components such as calcium, oxalate, and citrate, all of which predispose to stone formation. Given these findings, lifestyle interventions such as diet modification and increased exercise, similar to recommendations for humans, may be valuable preventive strategies for hyperlipidemic dogs with calcium oxalate uroliths, although further studies are needed to confirm this. Segment 4. The less common, yet crucial stones, purine and cystine. While struvite and calcium oxalate dominate, other stone types require unique management strategies, including purine and cystine uroliths. Purine uroliths, primarily ammonium urate, are the third most common mineral type in dogs and cats. These stones form when urine is oversaturated with urate and ammonium and often occur secondary to liver disease, typically a portosystemic vascular shunt, or due to an inborn error of metabolism causing hyperuricaturia, famously seen in Dalmatians. Dalmatians have a unique metabolism that results in them excreting significantly higher amounts of uric acid in their urine compared to non-Dalmatian dogs. This is due to a mutation in the SLC2A9 gene, which affects the transport and subsequent conversion of uric acid to allantoin, the more soluble end product. For patients with liver disease causing urate stones, dissolution is often impossible without correcting the underlying shunt. For dogs without liver disease, dissolution is attempted by combining a purine-restricted, alkalinizing, diuresing diet with the administration of allopurinol, a xanthine oxidase inhibitor. Allopurinol prevents the formation of uric acid, which can sometimes lead to the formation of xanthine stones if dietary purines are not restricted adequately. Prevention in non-liver disease dogs relies on the continued feeding of the low-purine diet, sometimes with a lower dose of allopurinol. Cystine uroliths result from cystinuria, a proximal renal tubular defect in the reabsorption of the amino acids cystine, ornithine, lysine, and arginine. While cystinuria itself does not guarantee stone formation, it is a significant risk factor. These stones are most common in male dogs and have shown a significant nonlinear increase in proportion of total stone submissions over recent years. Cystine urolithiasis is particularly notable because in intact male dogs, the condition may be androgen dependent, suggesting that castration might reduce cystine excretion and potentially cure this form of genetic urolithiasis. A recent study of intact male dogs with cystine stones found a statistically significant decline in urinary cystine/creatinine concentration 30 and 90 days after castration. For the dogs evaluated, the median decrease in urinary cystine/creatinine was 84% 30 days after the procedure. This profound decrease strongly suggests that castration should be considered for intact male dogs with cystine urolithiasis to help prevent recurrence and stop genetic transmission of the defect, potentially avoiding the long-term need for specialized diets. Although cystine stones have historically been regarded as radiolucent, modern studies show that they are frequently visible on radiographs. Dissolution of cystine uroliths in dogs can be achieved medically by feeding a low-protein, alkalinizing, diuresing diet combined with the drug 2-mercaptopropionilacin, or 2 miles per gallon. This drug binds to cystine molecules, preventing the formation of the insoluble cystine molecule. Cats do not tolerate 2 miles per gallon well, so it should not be used in feline patients. Segment 5. Finding the stones. Diagnosis and imaging. Accurate diagnosis is paramount in urolithiasis management, requiring a multimodal approach incorporating imaging, urinalysis, and stone analysis. Imaging is the most definitive tool for detecting stones. Abdominal radiography is often the initial modality used, as it can detect radiopaque stones such as struvite and calcium oxalate. However, radiography alone is often insufficient. Contrast radiography is necessary to rule out radiolucent stones, including urate, cystine, silicate, and mixed composition uroliths. Double contrast cystography is considered more sensitive than plain radiography, pneumocystography, and ultrasonography for detecting and enumerating bladder stones in dogs. Specific radiographic features can help predict stone composition. Calcium oxalate uroliths are typically highly radiopaque and are significantly associated with concurrent mineralization in the upper urinary tract. They are often present with unique shapes like bossylated, bumpy surface, or spiculated, sharp projections, suggesting a strong relationship between mineral composition and morphology. They are less commonly ovoid. Struvite uroliths are often larger, with a cutoff of 11 mm effectively discriminating them from other types, given their rapid growth rate. They are associated with pyramidal shapes and a tendency to appear as a solitary bladder stone. Cystine uroliths have lower radiopacity compared to struvite and calcium oxalate, a key feature for identifying them, though they are often still visible on radiographs. A low quantitative opacity ratio, urolith to L5 vertebra ratio, below 0.83 was found to be a good discriminator for cystine stones. Ultrasonography is also crucial for detecting stones, including those that are radiolucent, and helps verify the stone's location, number, size, shape, and density. Beyond imaging, urinalysis provides important clues. The presence of crystals, known as crystalluria, suggests crystalline oversaturation, though it does not definitively confirm the presence of uroliths. Crystalluria must be assessed quickly using freshly collected urine, because temperature changes and elapsed time can cause crystals to form artificially outside the body, leading to a false positive result. Urine-specific gravity suggests the concentration of stone precursors. Urine pH is also critical, as it dictates the chemical environment. Calcium oxalate, purine, and cystine stones typically form in acidic urine, pH less than 7.0, while struvite stones form in alkaline urine, pH greater than 7.0. Finally, urine culture and sensitivity testing is indicated in all urolithiasis cases, as infections may either cause struvite stones or occur secondarily due to mucosal damage or incomplete voiding. Segment 6. Tools of the trade, removal and management strategies. Once stones are confirmed, the treatment goal is removal or dissolution, employing the least invasive methods possible. Lower urinary tract management. If medical dissolution is not an option or has failed, physical removal is required. Cystotomy, or surgical incision into the bladder, remains one of the most common procedures in small animal practice, especially for removing uroliths. The preferred approach is a ventral midline incision to avoid damaging vital structures located within the lateral ligaments, providing excellent visualization of the ureteral orifices and the luminal surface. When closing the bladder, synthetic absorbable monofilament suture material is used in 1 or 2 layers, always incorporating the crucial submucosal layer, which serves as the surgical holding layer. It is crucial to evaluate the closure for leakage, typically by insufflating the bladder with sterile saline. However, traditional open surgery carries risks, including a reported rate of incomplete stone removal that varies from 14% to 20%. This has led to the rise of minimally invasive techniques. Percutaneous cystolithotomy is an attractive, minimally invasive alternative for removing bladder and urethral stones. This technique offers rapid postoperative recovery, often allowing discharge within 24 hours, and is associated with few major complications. Critically, this procedure does not depend significantly on the patient's sex, size, or stone burden, making it suitable even for male cats and small male dogs where transurethral cystoscopy is difficult due to narrow urethral diameters. The procedure involves performing a small incision, typically 1 to 1.5 centimeters, over the bladder apex and using stay sutures to secure the bladder to the abdominal wall. A trocar and cystoscope are then introduced to visualize the bladder lumen. Stones are grasped and removed using specialized baskets, or if they are large, the trocar is removed and the stone is pulled through the incision. Complete stone removal rates are higher with percutaneous cystolithotomy compared to surgical cystotomy, making it an excellent approach. Another option, voiding urohydropropulsion, is used for removing small calculi. The patient is sedated or anesthetized, the bladder is filled with sterile crystalloid solution, and then the patient is held vertically while the distended bladder is manually expressed. This technique can retrieve stones up to approximately 1 millimeter in male cats and up to 10 millimeters in female dogs. For larger stones, or stones embedded in the urethra, lithotripsy may be required. Laser lithotripsy uses a laser fiber passed through a cystoscope's operating channel to fragment the stones, allowing the resulting fragments to be removed transurethral. Upper urinary tract management, uroliths. Upper urinary tract stones, especially in the ureters, pose immediate, serious threats. Most uroliths in dogs and cats are calcium oxalate, meaning they cannot be dissolved medically and must be addressed physically. Immediate intervention is critical when a ureteral obstruction is confirmed, regardless of stone composition, because prolonged obstruction results in significant, irreversible kidney damage. The pressure generated by an obstruction severely diminishes renal blood flow, dropping to 40% of normal within the first 24 hours and leading to permanent loss of function, if not promptly relieved. While traditional surgical options like ureterotomy and ureteroneocystostomy carry high complication rates, exceeding 30% in cats and about 35% in dogs with high mortality rates, minimally invasive procedures are strongly favored. Medical management should be attempted first in stable patients, involving aggressive intravenous fluid therapy to promote diuresis, often combined with alpha-adrenergic blocking agents. However, if the patient is unstable or fails to improve within 48 hours, immediate renal decompression is necessary. The use of a double pigtail ureteral stent is considered a safer and highly effective minimally invasive treatment for obstructive uroliths. Stents immediately decompress the renal pelvis, stabilize azotemia, allow passive ureteral dilation for stone passage, and prevent stricture formation. In cats, due to the small ureteral diameter, stent placement is often performed surgically with fluoroscopic assistance, achieving a success rate over 95%. For cats with severe complications like ureteral strictures or obstructions where stent placement fails, the subcutaneous ureteral bypass procedure can be considered. This device involves placing a tube from the kidney pelvis, nephrostomy, directly to the bladder, cystostomy, bypassing the entire ureter and connecting the two segments subcutaneously to a shunting port. This is a salvage procedure that offers favorable long-term outcomes and is associated with fewer and less severe complications than ureteral stents in cats. Medical dissolution in the upper tract. While most ureteral stones are calcium oxalate and require removal, upper urinary tract Struvite uroliths can be successfully treated with medical dissolution. In dogs with suspected Struvite nephroliths and ureteroliths, a combination of a dissolution diet, targeted antibiotics based on culture, and ureteral stent placement, if obstruction is present, has proven effective. Given that many of these dogs present with infected urine, pyonephrosis, and sepsis, medical dissolution avoids the high risks associated with traditional open abdominal surgery. A retrospective study confirmed that this combination successfully dissolved all ureteroliths and nearly all nephroliths suspected to be Struvite in a series of dogs. The process is not immediate, however. Initial dissolution was observed at a median of about 1 month, with complete ureterolith dissolution occurring at a median of 3.9 months and nephrolith dissolution taking 5.3 months. The success hinges on accurate prediction of the Struvite composition, continuous administration of appropriate antibiotics throughout the extended dissolution period, and the ability of the stent to decompress the kidney and allow the antibiotic and diet to work effectively. Segment 7. When things go wrong, surgical complications and uroabdomen. Despite advances in surgical and interventional techniques, complications remain a risk in lower urinary tract surgery, especially for cystotomy and urethrostomy procedures. Urethral stricture or stenosis is a significant complication that can follow surgical repairs, urethrostomy, or trauma, often leading to partial or complete urinary outflow obstruction. The healing of the urethra involves epithelial migration, fibrous protein synthesis, and scar contraction. If tissue loss occurs, the resulting granulation and fibrous tissue proliferation can contract, leading to luminal narrowing or stricture. Conservative management of short strictures sometimes involves balloon dilation with fluoroscopic or cystoscopic guidance, followed by placement of an intraluminal stent for a period of 5 to 14 days to maintain diameter and promote proper healing. For strictures in the penile urethra, permanent urinary diversion via urethrostomy proximal to the obstruction is often the preferred treatment option to avoid the difficulty of primary repair and control hemorrhage from cavernous tissues. Cystotomy dehiscence and urine leakage are uncommon but serious complications, typically occurring within the first 5 days after surgery. The primary cause is imperfect technical closure, such as failure to incorporate the critical submucosal holding layer, inappropriate suture choice, or not failure. Dehiscence leads to the accumulation of urine within the peritoneal cavity, a condition known as uroabdomen. Uroabdomen can arise from surgical leakage, invasive techniques like catheterization, blunt trauma, or overzealous manual expression of the bladder. The presence of urine in the peritoneal cavity causes vague clinical signs due to uremia and peritonitis, and it is critical to remember that a patient's ability to void normally does not rule out ongoing leakage. Definitive diagnosis requires analyzing abdominal fluid obtained via paracentesis. Uroabdomen is confirmed when the concentration of creatinine in the abdominal fluid sample exceeds that measured in the serum. This occurs because the large creatinine molecule is retained significantly longer within the peritoneal cavity than the smaller urea molecule, which passes readily back into the bloodstream. Immediate surgical intervention is contraindicated in patients that are metabolically unstable. Patient stabilization is a twofold process. 1. Correction of metabolic imbalances. Aggressive administration of isotonic fluids, such as 0.9% saline solution, is initiated to correct dehydration, azotemia, and dangerous electrolyte imbalances like hyperkalemia. Hyperkalemia can cause severe cardiac abnormalities, including bradycardia and widened QRS complexes. 2. Continuous urine drainage. A route must be established for continuous drainage of urine from both the bladder and the peritoneal cavity. A transurethral catheter helps decompress the bladder and reduces urinary leakage. For effective drainage of the peritoneal fluid, specialized trocar-mounted, multifenestrated abdominal drainage catheters, or a sump drain fashioned from a balloon-tipped catheter and a Penrose drain, may be placed. Once the patient is stabilized, imaging like positive contrast retrograde cystourethropy is performed to localize the site of leakage before definitive surgical correction is undertaken. If leakage from a bladder incision is documented post-surgery, non-invasive management involving the placement of a transurethral catheter to keep the bladder decompressed for 24 to 48 hours may allow the leak to seal without requiring reoperation. However, persistent leakage necessitates surgical revision. The specialized uroepithelium lining the bladder and urethra has a remarkable regenerative capacity, allowing for rapid healing. The bladder, particularly, is unique because it can regain 100% of its strength within 14 to 21 days after an incision, which is far faster than most other hollow organs. This regenerative power is a key factor enabling successful surgical interventions and minimizing complications when basic surgical principles are meticulously followed. Thank you for listening. The titles for the reference papers are in the video description. From VetMed Digest, where we keep minds inspired, hearts light, and tails wagging.